Good evening, ma'am. Good evening, sir.
Good evening.
I'm presenting the details of Mrs. L, a 46-year-old female. She's from Yemen. She has completed class 12th as formal education, and she's a homemaker. The history is given by the patient herself. She speaks Arabic. The details are noted by me with the help of a translator. She has come to us as a prospective renal transplant recipient with her nephew as a donor. The history is obtained by me on post-operative day 2 of renal transplant surgery. Since her complaint started 3 years ago, that is in 2019, I am presenting her details since then on. She was apparently healthy till 3 years ago when she started to have headaches, usually frontal and occasionally involving the occipital area, at an average of 1 to 2 episodes per month, throbbing in nature, for which she used to take oral painkillers and injectable painkillers from a nursing home on OPD basis. These headaches were associated with episodes of vomiting. There was no history of fever or vision disturbance associated with these headaches. She never underwent any blood pressure checkups. There were no urine or blood tests done for these headaches. These complaints persisted for 2 years till June 2021, when she developed headache again. This time it was very severe in intensity, associated with 1 episode of vomiting, for which she was taken to a local hospital and was told to have high blood pressures. She was treated with injectable BP medications, and she was discharged on oral tablets for blood pressure control from the emergency department. And she was asked to come for an OPD follow-up after 2 days. During her next OPD visit after 2 days, she underwent blood and urine tests, and she was told that she has protein loss in urine and she has a high serum creatinine. At this point of time, she had a normal urine output, both in quantity and frequency, as it was before. There was no history of edema of the feet or shortness of breath or palpitations. There was no history of blood in urine or frothuria or graveluria. There was no history of easy fatigability or weight loss or fever or pain in the joints. There was no associated epistaxis or nasal crusting. There was no history of polyuria or nocturia ever. There were no history of recurrent episodes of UTI in the preceding this event. There was no history of over-the-counter medication intake except for painkillers, and she doesn't know the details of the painkillers she has taken. On evaluation, an ultrasound was done at her place, and she was told that the kidneys are too small, and she couldn't undergo a kidney biopsy, since she was told that there was no use performing a kidney biopsy on such small kidneys. At this point, she was told that her serum creatinine was 6 milligram per deciliter, and she will be requiring initiation of hemodialysis very soon, and will require a renal transplant as a definitive treatment option. However, she continued to be on medical management with an injection to increase her hemoglobin levels. There was no history of blood transfusion needed, and she was given BP medications for the control of her blood pressures. Over the last 1 year, the only complaint she has was there was a significant history of weight loss, that is 18 kilos over 1 year, and she has reduced appetite. For the same, she underwent a workup for a live-related renal transplant with her nephew as a donor at her place, and she was told that her nephew might not be a good match since there is some abnormal result in the compatibility test done, though the blood groups are same. Hence, she came to us for further evaluation and management and for a kidney transplant. When she presented to us, she complained of reduced urine output observed since 1 month duration, and it is associated with swelling of the feet up to ankles. When we evaluated her, we found that her serum creatinine was 10.7 milligram per deciliter, and she has severe metabolic acidosis. Hence, she was initiated on a maintenance hemodialysis, and her ultrasound also showed bilateral shrunken kidneys, 6 centimeters in size, and so she was initiated on a maintenance hemodialysis with right IJV HD catheter as an axis from 15th of August 2022. She tolerated the hemodialysis sessions well. Meanwhile, she was worked up for renal transplant with nephew as donor. On evaluation, she was told that her cross-match with her nephew is positive. She doesn't remember the finer details regarding the cross-match, and she was advised to get a more specific test for the same. And based on the report of this more specific test, she was advised to receive a costly injection 2 weeks prior to transplant and to undergo plasma exchange. She underwent hemodialysis and plasma exchanges on alternate days. A total of 5 plasma exchange sessions were given. And she remembers that the day prior to the transplant and after her last session of plasma exchange, she received 2 units of plasma transfusion. She underwent live-related renal transplant on 2nd of September. Her intra-op course was uneventful. She had good urine output in the immediate post-op period. Today's I have taken the history on post-op day 2, and she has good urine output. Graft function, as what she knows is her serum creatinine is 0.8 milligram per deciliter, and she doesn't have any complaints at present. Can I proceed with the past history?
Yeah, complete the whole history. Yeah.
Her past history, she is not a diabetic. She has been detected with hypertension and chronic kidney disease 1 year ago and is on medical management. She is euthyroid. There are no history of any blood transfusions. There is no history of fever or any infection in the recent past. There is no history of any major surgery in the past. Her obstetric history, she was married at the age of 13 years. She had 3 pregnancies with her first husband. All her she was a booked case during that time. All the antenatal checkups were done on a regular basis, and antenatal history was uneventful. She had a first baby boy who succumbed to pneumonia at 2 months age. Second was an abortion, and she has a third child who is healthy, alive now. With second husband, she had 6 pregnancies. All pregnancies were booked cases with uneventful antenatal history. All children are healthy, and she remembers all her children were more than 2.5 kilos birth weight, except for the last child who was born 10 years ago. His birth weight was 2 kilos at that time. Even during her last childbirth, her blood pressure was normal. All the blood reports and urine reports, as what she remembers, are normal. Family history, there is no diabetes or hypertension in the family, no kidney disease in the family. Siblings are all healthy. Parents are at present not alive. She says they died because of a natural death and aging, and there is no kidney disease even in the parents. Vaccination details, she received hepatitis B vaccination. She never had COVID infection. She received 2 doses of COVID vaccination. Treatment history, she received blood pressure medications. She remembers the name of one, which is amlodipine.
Anything else in the history? I think you have enumerated good history. There was some points which I want a clarification on. One is the menstrual history. You have said her obstetric history, that she had 9 pregnancies in all previously.
Yes.
You said she was married at 13 years?
Yes, sir, 13 years, and she is now 46 as per her
46.
passport.
She has 9 pregnancies during this time, and last was 10 years ago.
Yes, sir.
There was no problem during pregnancy, what she remember of.
Oh, sir.
Okay. And the menstrual history?
Menstrual history was absolutely normal, sir. And even now she says she has regular menstrual cycles, okay. 5 per month cycles even now. Okay. I mean, sorry, 5-day cycles even now.
Because more often than not, most of them will have some dysmenorrhea during because of renal failure. So that's also important in female patients.
Yes.
Okay. Rest all you said is all right. So she never had any blood transfusion even during deliveries and pregnancy?
No, sir.
So you said there was no history of nocturia in this patient.
Yes, sir.
Why do people have nocturia? I mean, why did you ask that?
Sir, the way she was presenting, there was no history of edema, and there was no reduced urine output. I was thinking probably I'm dealing with a case of chronic tubulointerstitial nephritis. So patients with tubular disorders, they present with nocturia, and patients with CKD due to CTINs present with nocturia. For that, I have taken that history.
So when do you call nocturia?
When a person has to wake up in the night to void at least twice in the night after the person goes to bed.
Why do they have nocturia? The patients who have chronic kidney disease, why do they develop nocturia?
Sir, usually antidiuretic hormone, the production during the nights, the production is, urine gets concentrated because of the good tubular function during night. That is why normally we do not go for a void in the night. But somebody who is having a tubular dysfunction, that concentration ability is lost.
Okay.
So
why not in the daytime? So what happens in the daytime?
sir, they probably
Doesn't
observe it
disturb
more
you.
in the night.
So you don't notice it.
Yeah.
They
So
observe it in the night more.
what is the normal capacity of the bladder? When does one feel urge to pass urine?
Sir, 200 to 250 ml.
So that's the first urge usually,
First urge.
which you can easily suppress, and most of the patient will have a desire to pass when the bladder is around 300 or 400,
Yes, sir.
right?
Yes, sir.
So if one assumed that one drink a normal amount of water, which will determine the urine output in general, so they will produce, say, around 2 liters of urine. Most of the time in the night, as you very rightly said, the kidneys, you don't drink water and the body perceives it as concentrating stimuli and they concentrate the urine. Whereas in patients who have renal failure, they cannot concentrate the urine.
Yes,
So they make same amount of urine as they produce in the daytime. In the daytime, you don't notice it. Anyway, you are awake and you go for urination whenever the bladder is full. But in the nighttime, whenever the bladder gets full, they have to get up and go for the urination. So they pass 1 liter in the daytime and 1 liter in the nighttime. So at least more than 2 times if they wake up in the night, that means that they cannot concentrate the urine. And that's why they have to get up. Good. So what do you think is the cause of a renal dysfunction?
Sir, I would consider she has a chronic tubulointerstitial nephritis that has caused a CKD in her.
Why do you say that?
Preserved urine output, even when she was diagnosed at end-stage kidney disease, no history of edema or fluid overload any point of time.
Yeah. So that will make it chronic interstitial nephritis. How common is chronic interstitial nephritis? If you see 100 patients who present to you now with advanced renal failure requiring dialysis, so what proportion of this will be chronic interstitial nephritis? So what is the commonest cause of chronic kidney disease?
Diabetic kidney disease.
Diabetic kidney disease, yes. And then second?
Chronic hypertensive kidney disease, and then chronic
Hypertensive nephropathy or chronic glomerulonephritis. Okay. So in Western world, where you see more of aged population, where you can see hypertensive nephrosclerosis, whereas in India, most of the patients they develop renal failure very young, at a very younger age. So usually glomerulonephritis is other common cause, second commonest cause. And chronic tubulointerstitial nephritis in Western world is reported in somewhere around 5%. If you look at USARDS data, it's around 5%, less than that. Whereas in Indian data, there are a couple of series which were published from Sanjay Gandhi PGI, Vellore, and All India Institute. There, the prevalence is around 15%. It's somewhat higher in India, but still not the commonest cause. And almost 60 to 70% patients, when they present with advanced renal failure, the first time present with advanced renal failure, they have no history of edema or decreased urine output. So that doesn't make most of them as chronic interstitial nephritis. Okay, so even if you have history of edema and volume overload, that will suggest that this probably is glomerular disease. But if there is no such history, that does not exclude glomerular disease. So it can still be glomerular disease, okay, which has been a silent disease progressing. And when she developed hypertension and advanced renal failure symptomatic, that's when you found that she has advanced kidney disease. So when you have no indicator as far as interstitial nephritis or chronic glomerulonephritis, look at the statistics. What is the commonest disease? She is not diabetic, so second commonest is glomerular disease. right? So it could be chronic glomerulonephritis, or then it could be chronic interstitial nephritis. Okay. So nephew is the donor. So nephew, how is nephew related to her?
Sir, her elder sister's son he is.
Son. Okay. So there is some problem which they found in their own country, and that's why they have come here.
Yes, sir.
And then she had cross match which was positive, and then desensitized properly, and then has undergone a kidney transplantation.
Yes, yes, sir.
So why do you think she developed this sensitization? So she basically is a sensitized individual.
Sir, multiple pregnancies, 9 pregnancies, and that to 2 partners. That is a good enough reason for high sensitization.
So multiple pregnancies. What are the other reasons for sensitization?
Sir, blood transfusions.
If somebody has received previous blood transfusions.
And second transplant, previous
Transplantations. Okay, so she has had multiple pregnancies earlier, so that could have sensitized her, and now she has come with for kidney transplantation. Okay, so anything else? I think examination. You want to complete the examination?
Yes, sir. On examination, sir, even examination was done on post-op day 2.
Okay.
Yes, sir. She is conscious, cooperative, well-oriented to time, place, and person. Her weight is 46 kilograms. She is afebrile. Heart rate is 84 per minute. Pulse is regular, normal volume, and all peripheral pulses are felt. Her respiratory rate is 14 per minute, regular. Her blood pressure is 128 by 60 millimeters of mercury as measured in the right upper limb in the supine position. She has pallor. There is no icterus, cyanosis, clubbing, or lymphadenopathy. She doesn't have edema. Head-to-toe examination, skin, hair, nails, normal. And fundus examination is normal. And head-to-toe examination is otherwise essentially normal. Systemic, can I proceed with systemic examination? Systemic examination per abdomen is soft. There is an incision site. Incision site is bandaged, and there is no graft tenderness. There is no bruit over graft area, and bubble sounds are normal. Examination of cardiovascular system, apex beat is not visible. It is palpable in the left fifth intercostal space, half an inch medial to the midclavicular line. First and second heart sounds are normal. Respiratory system, chest is symmetrical, expanding equal on both sides with each respiration. Bilateral vesicular breath sounds are heard, and there are no added sounds. Central nervous system examination, she is conscious, oriented, her higher mental functions are normal. Motor and sensory system examination is normal.
Did you examine the fundus?
Yes, sir.
So what do you expect on fundus examination?
Sir, I was looking if it would be a hypertensive retinopathy.
So what is hypertensive retinopathy?
End organ damage due to chronic hypertension.
No, that I know. But what do you look for? When you see the fundus in patients who have hypertension, what do you see in the fundus?
It used to be a classification, grade 1, 2, 3, 4. Ramya, you may have heard of it. Yeah.
Narrowing of the blood vessels.
That's grade 1.
Grade 1.
Spasm types.
So where is the narrowing? What gets narrowed?
Arterial branches, Ramya. What else will get narrowed there?
It's the crossing. See, when the artery crosses the vein, okay, so there because of compression, the artery gets narrowed as compared to vein. Okay, what else?
Sir, there is nicking.
That is,
नेकिंग तो यही थी,
यही है narrowing जिसको आप बोल रहे हैं.
एक वायरिंग होती है.
Copper wiring.
हो गई एक वायरिंग.
What is copper wire and what is silver wire?
हाँ, कुछ कॉपर वायरिंग, सिल्वर वायरिंग कुछ होती है.
And why do you see copper wire and silver wire?
Sorry, I do not know.
Okay. Did you really look at the fundus or you didn't?
Yes, sir. I tried looking.
Okay.
I didn't.
But you didn't know what to see. So what mind doesn't know, eyes can't see. Right? So any patient who have hypertension, long-standing hypertension, they have hypertensive changes in the vessel. And most of them, these changes are atherosclerotic changes in the arteries. Initially, there is kinking of the veins, retinal veins, because of arterial compression. Second stage is copper wire, because the wall gets thickened, and because of reflection of blood through that thickened wall, it appears as yellowish, copperish. And when there is further thickening of the arterial wall, it just looks like silver, white. You can't see the reflection of blood across. Okay, and then there are papilledema as the accelerated hypertension and exudates.
Cotton wool spots.
No, cotton wool exudates are infarct, retinal infarct. They occur in acute hypertension. Okay, so hard exudates, yellowish exudates, they are dissipated cholesterol. Okay, so the cholesterol deposition in the retina, or that's usually visible as hard exudates. Okay, so these are the changes which you see in the eye in patients who have hypertension. If you see a vasospasm, arterial spasm, papilledema, or cotton wool exudate, that indicates acute hypertension. Okay, so these are the changes you see in the eye. Okay, so examination was really unremarkable. So she's post-operative day 2. So most of the changes for say volume expansion, everything has reverted. And she was making good amount of urine, so looked all right. Good. So if you're managing this patient, what do you expect? Say, what was done? Say you said all the investigation or workup for kidney transplantation was done, and the cross match was positive. So which cross match? What are the types of?
She'll have to come to tests now because she doesn't have those dates historically. I think she'll need to come to that.
I'm just asking what are the types of cross match? How would you proceed? This is a patient who has come to you for kidney transplantation.
Yes,
So what are the relevant issues here before you proceed for kidney transplantation?
So in other words, where will you start, Ramya? I mean, in terms of ordering your lab tests beyond the physical examination of the donor this time.
Donor?
No, so donor and recipient, you take them as a
if you are the
combination.
okay, let me reframe my question. So
Yeah,
you are the
rephrase
treating
it.
nephrologist,
Yes, sir.
right? And this patient has come to you, as you said, from Yemen for kidney transplantation with a prospective donor. Nephew is a prospective donor, right?
Yes, sir.
So in addition to evaluate her for requirement of dialysis and starting dialysis and optimizing her medical treatment, which you have already done,
yes, sir.
now how will you plan a kidney transplant in this individual?
Sir, first I will get the HLA typing of the donor and the recipient done.
Okay, but why do you want an HLA typing?
Sir, one is to establish relation.
Okay.
And second is to look at the risk also, risk assessment.
What risk?
Sir, transplants which have zero mismatch, they do well compared to the graft loss is less when compared to the
immunological risk.
immunological risk.
So one is you will assess the immunological risk for this individual. So
Yes.
how much is the risk of immunological injury to the graft?
Yes,
Okay.
sir.
And one factor which will determine it is the HLA matching between the donor and recipient.
Yes, sir.
So that's why you will do an HLA match and see how good is a match and how much is a mismatch.
Yes, sir.
So what is more important, match or mismatch?
Mismatch.
Why?
Sir, antibodies are produced against the mismatched antigens of the donor by the recipient.
Good. So you will see how much is the mismatch and
Yes.
and categorize the risk according to the number of matches and mismatch. What else?
Sir, then I would do a complement dependent cytotoxicity and a flow cross match.
Okay. So what do they assess?
Sir, they assess the presence of donor specific antibodies.
So what is the difference between CDC cross match and flow cross match?
Sir, in CDC cross match, it specifically identifies the complement mediated antibodies.
Complement mediated antibodies.
Yes, sir. And it requires a high titer of antibodies for it to be positive. Flow is a better and sensitive test, identifies even low titer antibodies.
Okay, so then why not only do flow if it is better test? Why do CTC cross match? You said flow cross match is better than CTC cross match.
It is sensitive for antibody titers, sir.
So do it. You want that test? Why do you want to do CTC cross match?
Sir, a positive flow cross match doesn't always mean that that there is a high chance of graft loss or immediate graft loss will be high.
Why?
So by just doing a flow cross match, we may deprive some patients actually who may do well post transplant of a donor, of a renal transplant.
Then why do flow cross match? Why not do CTC cross match only? So what do you look for? Suppose you do CDC cross match. So do you know how it is done?
Yes, sir.
How is it done?
The donor lymphocytes are taken and to which the recipient serum is added and complement is added to it. And complement binding antibodies, which if at all present in the recipient serum, will bind to the donor lymphocytes and they cause the lysis of the cells. Based on the percentage of the lysis of the cells, we stratify the CDC into positive or negative.
Positive or negative. You're very right, right? So there are antibodies present in the recipient serum,
yes,
and
sir.
the cells are donor lymphocyte. If
Yes.
there are antibodies present in the serum, they will bind to the lymphocytes. But to cause the lysis, they will need complements.
Yes.
So they will activate the complement system and then cause the lysis of the cell,
Yes.
right? So that's why you add complement and that will precipitate the cell lysis. And you will know that there are antibodies which can injure the graft cells,
Yes, sir.
right? So how is flow cross match then?
In flow cross match, the donor lymphocytes are taken and recipient serum is taken.
Mhm.
And to this, fluorescent tagged anti-human globulins are added. Like the antibodies against the immunoglobulin, human immunoglobulins are added.
Mhm.
If at all there is a binding of the antibodies to the cells, to the donor lymphocytes, they are highlighted by these fluorescent tagged antibodies, anti-human immunoglobulins. And that is read as a median channel shift.
Yes. So in this, there's no need to cause cell lysis, right? So there are antibodies in the serum. They will bind to the donor cells. And now you will detect these antibody by adding antibodies, right? Anti-human antibody, which are tagged by fluorescein. And you see whether there are antibodies present on the donor cells. So there is no need for the lysis of these cells, right? So if there are antibodies which do not activate complement and cause cell lysis, even these antibodies will be detected. So that way it is more sensitive, but it will have more of false positive test. So it will also detect irrelevant antibodies which cannot cause graft injury. Okay. So you may reject many patients who can still be transplanted just because they have some antibodies which are not useful as far as graft outcomes are concerned. Okay. So you will do CDC cross match, which will detect the harmful antibodies, but in the higher titer. You will do flow cross match, which will detect antibodies even in the lower titer, but there may be no harmful, so maybe some harmful, some non-harmful antibodies. Okay. So this patient has positive cross match. So let's assume the flow cross match or CDC cross match is positive, right? So what will you do?
Sir, I will look at if the CDC cross match is strongly positive, I would not want to take this person as a donor for this recipient.
Okay.
If at all the flow cross match is positive, I would look at how strongly it is positive. I would look at the intensity values. If the median channel shift is high, then maybe I will not prefer to prefer this donor as a donor for the recipient. So I will then perform a donor specific antibody test using single antigen bead.
So how much channel shift is there usually when you say that the test is positive?
Sir, 250 is the cutoff. If more than 250 median channel shift is there, it is not warranted to transplant the patient with that particular donor.
So which B cell cross match or B cell cross match?
Sir, T and B cell, if both of them are 250, more than 250, T cell definitely is more significant and important.
Why?
Sir, the rejection is T cell mediated rejection, that what we come across. Like
You're taking cells from the donor.
yes, sir.
And the rejection is caused by recipient cell, T cells.
You confused.
No, I'm not confusing. Say which HLA is expressed in which cell. So that's what will determine
Class one.
which cell cross match
So
is possible.
T cell expresses both.
Class 1, T cell expresses class 1, B cell expresses class 1 in higher quantity, and also class 2 MHC molecules.
Yes. Okay. So if the T cell cross match is positive and B cell cross match is negative, so what will that indicate?
That cannot happen, sir.
Why?
Technical.
Sir, if T cell cross match is positive, it means there are antibodies against class 1 antigens.
Okay.
And the class 1 antigens are more represented in B cells when compared to T cells. So B
Yes.
cells should be positive. So if that is positive, the test is wrong.
So there may be some error in the test, and you will see why this is positive. Okay.
Yes, sir.
So if both are positive, then obviously it is positive. But if B cell is positive and T cell is negative, that means
Sorry, sir. T cell is positive, B cell is negative, cannot
T cell
happen.
is negative, B cell is positive.
B cell can be positive when there are low class 1 HLA antibodies present, or class 2 HLA antibodies present, or in the presence of autoantibodies in certain cases.
Good. So usually the channel shift which we consider, it varies from lab to lab, but generally for T cell it is more than 50 channel shift. For B cell it is more than 150 channel shifts. Okay. So whenever you get a report of positive cross match, you should talk to the lab and see what is their cutoff and how much was the channel shift. Okay. But if the channel shift is more, as you said, more than 250 or more than 300, it is considered as strongly positive. And then you have to really work this donor up and see whether you really want to take this donor or not. So the CDC is negative, flow is positive. What will you do?
Sir, I will go with the single antigen bead test and look if antibodies are against the specific HLA of the donor or not.
So what will single antigen bead test tell you?
That will tell the specific unacceptable antigens, absolutely unacceptable antigens for the transplant.
Unacceptable. What is unacceptable?
Sir, if at all the recipient is producing significant titers of antibody against the donor antigens, that is called as an acceptable antigen.
So you will specifically look for donor specific. Say, so you know the donor HLA, and you will see whether the antibodies are specifically against this HLA and how strong or what is the titer of these antibodies.
Yes.
Okay, so you will see the donor specific antibodies to a specific HLA and the strength of that antibody titer, how strongly it is positive, and based on that you will make the decision. Okay. Good. What else? One is you will evaluate the immunological risk, and accordingly you will plan the immunosuppression. What else you want to see before you proceed? When you do a donor and recipient pre-operative evaluation?
Sir, we will blood group matching, sir.
Blood group anyway you will match. Incompatibility, ABO compatibility or incompatibility.
Yes, sir.
So the common question which patient asks is, doctor, will this disease happen again in my graft? Isn't it?
Yes, sir. Sir, I cannot tell with certainty until unless I have a biopsy and the cause of native kidney disease I know with certainty. If not, I cannot tell. But
So in
again,
this patient, you said the graft is 6 centimeters. You cannot, I mean, you can biopsy it, but there is a high risk of complication. So, and it may not give you an answer to what was the cause of her kidney disease.
yes, sir. Yes.
So should she go for transplant? Should she not go for transplant?
She should go for transplant.
Why? If the disease will recur in her graft? What is the possibility? So even if you don't know, so this is a patient with chronic kidney disease where you do not know the cause, unknown cause. Okay, so what is the chances of recurrence? How common is the recurrence of primary disease? I know it varies from disease to disease, but if you just lump all of them together,
5 to 10%.
yes, so 5 to 10%. So there is a chance of recurrence 5 to 10%. Since we do not know the disease, we can't say it very certainly, but the chances are low. 90% chances that you would not have a recurrence. Right? So she can still go for the transplant. And the third thing which you assess the risk of infection. Okay? So the risk of recurrence, risk of immunological injury, and the risk of infection and other cardiovascular disease, cardiovascular morbidity and mortality. That's what you do generally, right?
Yes, sir.
Yeah. So after evaluating all these things, then you go for kidney transplantation. And for the donor perspective,
For evaluation, sir.
yes.
We will look at the GFR by using a DTPS scan. Look at the relative GFR of each kidney.
Mhm.
In addition to the routine tests, we will do that. Cardiovascular evaluation, definitely.
Why do you want to do all these donor tests? Donor said he is apparently healthy, never had any disease.
What's the basic purpose of this evaluation? That's what I think you need to say. So you assess his chances of developing kidney disease or the possibility that he may get chronic kidney disease, right?
Yes.
So you see how safe is for the donor. That's another question always asked.
Immediate safety.
The donor ko to koi problem nahi hogi na sir. Donor will be all right. They don't want 2 patients in the same family. Right? That's the commonest thing they will ask. So you evaluate the risk of chronic kidney disease in future. So what is the risk of this individual for developing CKD down, say, 10, 15 years? Right?
Yes, sir.
How common is that?
Sir, 1 to 2%.
That's very high. That's very high.
So 1 to 2% means 1 in 100 will develop. 1 to 2 people in 100 donors will develop chronic kidney disease over what time frame?
Over 20 years.
Over 20 years. So you think it is high? Is it risk worth taking or?
No, sir.
It's not worth taking. So if 2 donors will develop chronic kidney disease in 10 years or 15 years, people would not transplant, will not accept living donors. So are you aware of any such data? People must have looked at it.
Sir, I don't remember.
You don't remember. So this was the data, registry data, which was published in 2014. Okay. So in 2 continents, in Europe as well as in US. And the usual risk was, I think, around 67 per 1,000 donors.
I think it's 3.8 per 10,000 for normal population.
Yes.
No, the other way. I think it's 0.38 per 10,000 for normal population, and it's roughly 8 times in donors. I think it's that. It's 8 to 10 times in donors.
Yeah,
So
8 to 10 times.
Multiplication is high, but the absolute is very low.
Yeah, so the absolute risk, I think, was around 38 per 10,000 donors. And it varies from low, and the highest was around 97 over 15 years.
Yeah, somewhere.
So that's what was the use. Whereas in normal population, it was less. So if you look at relative risk, it is 6 to 8 times, but the absolute risk was not very high, right? So that's how it was considered. And then somebody has also looked at the risk factors. So what are the risk factors of developing this type of chronic kidney disease in future? Okay. So can you, guess what are these risk factors?
Yes, sir. Hypertension, smoking.
Hypertension and smoking. Okay. What else?
Sir, obesity, diabetes.
Diabetes, obesity, hypertension, obesity,
And
smoking,
smoking.
and age.
Yes, sir.
Okay.
Anything to do with ethnicity?
Ma'am, Africans and APOL1 gene carriers are at a high risk of developing
Yes.
CKD.
So African Americans and
APOL1 gene, sir, that is new.
yeah, that is usually go hand in hand with African Americans, not
Being
in
black.
otherwise general population. I think proteinuria and GFR, right? So these are 8 factors which will determine whether this individual
3.9 per 10,000 in normal population,
normal population,
non-donors.
Yeah.
So this is not normal population, healthy non-donors. That's what the registry did. And 30 per 10,000 in donors.
Yeah.
So that's what the figures are.
Okay. So of these 8 factors, which are the most important?
Sir, hypertension, proteinuria, EGFR to begin with.
Yeah. Hypertension, but you do accept hypertension. So it's very common. 1 in 3 individuals has hypertension. Right?
Yes,
So you must have seen during these 3 years that patients who come, they have hypertension controlled on one medicine, no target organ damage, and you accept these people.
Yes, sir.
Does age have anything to do with that acceptance or non-acceptance? That's something you should always remember.
Yeah.
So
I will come to it.
Sure, you must have heard this from me many times.
I will come to it.
Yeah, I will not accept a 40-year hypertensive, but I'll accept a 60-year hypertensive. That you may have heard by now.
So these are the important predictors. As in general population, these things will predict whether somebody will develop renal failure or not. Okay. So what is good? Say age, for example, you said. So you have 2 options. One is a patient or say daughter or the children of 30 years. Other is a parent which is 60 years. Or say spouse has 30 years and parent has 60 years. What is preferable?
Parent, 60 years old parent, sir.
Why?
Sir, at 30 years, again, early onset of hypertension is a risk factor for CKD.
No, she is not hypertensive. No one is hypertensive.
Achha, okay.
How do you
No one
make
is
a choice
hypertensive right
between a
now.
30-year-old and a 60-year-old?
So you have a patient who is
What's logic for that?
32-year-old. His spouse is a donor who is 30-year-old, prospective donor, and the mother who is 60-year-old.
Yes, sir.
Both of them are ready to donate. They have no disease.
But still, we will take a mother at 60-year-old.
Why?
Sir, her chance for progression for CKD will be less when compared to a younger patient at 30 years who will have a single kidney.
Why?
Sir, once we post donation, definitely there will be a compensatory hypertrophy, proteinuria, the onset of all this will start. So it is better the duration of proteinuria definitely determines the outcome of the kidney. That is CKD.
Everyone will develop proteinuria? No. Your answer is right. Right? So you would prefer a mother, whereas the mother will have age-related changes. So you always say, okay, elderly donor, low GFR, age-related changes in the kidney. Kidney is not going to do better in the recipient, but that's a recipient's perspective. For donor point of view, the mother has say 20 years to live. She is 60 years now. If you say she'll live till 80 years, she has 20 years to live. the chances of developing a kidney disease may be slightly higher, or say progressive decrease in GFR will be higher, but she might pass her lifetime without requiring any significant treatment for renal failure. Whereas a 30-year-old individual, if she will develop a disease, she has to go 40 years or 50 years from now. The chances of her ending up with end-stage kidney disease is higher. So the lifetime risk is higher for 30 years as compared to 60 years, right, of end-stage kidney disease. So generally, you cannot say evaluate these points in isolation. You have to look at a combined. So in an individual, you look at whether they're diabetic, they're hypertensive, they're smoker or not, and what is their age, and what are the chances of developing a significant kidney disease in next 15 to 20 years.
So there is another perspective to this, which I would like to add. Let's say this person needs a second transplant 15 years later. So the 30-year-old will still be available for donation, whereas the 60-year-old will not be. So that's something you can, this is not a donor perspective, but could be added to this reasoning.
Okay. So with that evaluation, you will take this patient for kidney transplantation. So now coming on to the test, which you said you will do cross-match, flow cross-match, and do you have the reports?
Yes, sir. Mr. Puneet, can you please just play that? Sir, I'm not able to share the
Sure,
screen.
ma'am, sure, sure.
You want to go to the immunological workup or other lab tests also?
I think, do we need other lab tests? I think
There's nothing specific in them.
Nothing is specific in that. So let's go, for the sake of time, maybe.
Time to be coffee, 7:20 only. But I think some of the audience wants to switch to the sensitization issue.
We'll come to it.
Yeah, somebody's asking questions on that. Okay.
So this is the HLA typing of donor and recipient.
Yes, sir.
So you will read it. How do you interpret that?
Sir, I shall read it out, sir.
Yeah.
Sir, can I read it out by?
No, interpretation.
How would you
I don't want you to read interpretation.
Interpret it in your head. That's what you need to say.
Yeah.
Sir, here I would look at the donor HLA typing first and match it with the recipient by looking at the number of mismatches here.
Yeah.
So in HLA-A, I could see there is a mismatch at 0 to 0.5 of the donor.
Mm-hmm.
In HLA-B, it is 50-01.
Yes.
And HLA-DR-B1, it is 0701.
Okay.
So
this is three mismatch.
Three mismatches.
Three matches.
3/6 and 3 matches.
Yes, and Puneet, can we just move it up?
Do we have the cross matches also here?
Yeah, ma'am, we have it.
Yes.
Yeah.
So this is the CDC cross match.
So small.
ये इतना छोटा क्यों आ रहा है?
हाँ, ये पहले जब initially
जब स्लाइड दिखा रहे थे तब तो अच्छा आ रहा था.
मैंने तो अपनी स्क्रीन को बड़ा कर दिया.
Actually, so there is a problem. My colleague was sharing. Now
CDC negative. Can we have it again?
Ma'am, CDC T cell is negative, B cell is weakly positive.
Right.
Ma'am, can I try a screen share from my side now?
It's readable right now.
Yeah. So
T cell negative. This is CDC. T negative. B cell weak positive. That's what it says.
So what does that mean?
Sir, it means they are antibodies against class 2 HLA molecules, or it could be or it could be
HLA class 2 molecule.
HLA class 2. Yes, sir.
Or it could be?
Or it could be autoantibodies.
Okay.
So do they, in the CDC cross match, normally the lab does something to eliminate auto cross match out of it?
Yes,
So what
ma'am.
do
They
they do?
do the DTT treatment with dithiothiotol. That
Right.
usually eliminates the autoantibodies, which are usually IgM. It breaks the disulfide bonds of the IgM antibodies.
So most labs would do this, but you can always confirm.
Yeah.
Eliminate?
So there is a comment here. So
Comment. Yeah.
Right.
So with and without DTT, B cells do show 25 to 30% lysis. So it is probably the class 2 HLA antibodies.
So it was same with or without DTT.
Yes, sir.
So it could be class 2 anti-HLA antibodies. So unlikely to be an autoantibodies.
Yes, sir.
Okay. Many lab also run auto cross match. So they run the same serum with their patient's lymphocyte, and that's another way to see the autoantibodies, right?
Yes, sir.
Okay. So then you did a flow cross match, and it
So-
also shows T cell negative and B cell weakly positive.
Yes, sir.
And they have written the,
MFI ratios are given here, sir.
okay. So
Yeah, the
MFI
SRL gives a
ratio is
different system.
They have a different system probably.
Yeah, they have a different system.
0.93 and B cell is 1.98.
Yes, sir.
Yeah, for them, I think less than 1.3 is negative and more than 1.5 is positive or something.
So
Yeah,
I
1.5 to
think
2 is.
whatever is
More
their
than
cutoff,
two
it is more than 50% above that cutoff, or say mean probably.
Yeah.
It's positive. Okay.
So my judgment is maybe 1.5 is somewhere 150 types of channel shifts. Maybe.
More than 2 is positive as per them.
Yeah,
More than 2 is positive. 1.5 to 2 is weak positive.
weak positive.
Okay.
Sir, if I may be permitted, can I try sharing the screen once?
You
I
have
think
it on
my-
your screen. Yeah, you can try your screen. Probably you might.
Yeah, it's come full screen.
Yes.
Ah. Yeah, better.
Is it visible, ma'am?
Yeah.
Bigger than previously.
Mm.
Yeah, much better.
So, yeah. So next is the single antigen bead report.
Okay.
So for the class 1, the MFI was less than 1,000.
For both A and B.
For both, sir, for class
So-
1 they have given, and for A and B, we have looked against the donor donor HLA. Both are within less than 1,000.
So A0201, A0205, both are less than 1,000.
Yes, sir.
And B5001 and 5101.
Yes, sir. Sir, we have to look at
All 4 represented here.
Sir, yes, sir. We have all 4 represented, and
Unlikely,
all are
Ramya.
negative, less than 1,000. Ma'am, for
One
this-
second, 0201. I think 0201 is missing. No, it's here.
No, it is there, ma'am.
It's there. Okay, you've checked all this?
I have checked all.
Okay.
Them.
Okay.
Chalo.
So
Because
So-
many times some are not represented.
these are represented, and we are looking at this the antibodies against the mismatched antigens.
Yeah.
The mismatched are HLA A205 and HLA B5001. For that, the MFI values are less than 1,000.
Yeah.
Perfect.
It's always better to look for the own antigen as well.
Yes, sir.
At times, there are a lot of background activity,
Yes, sir.
say widespread and some technical flaw or some. So that
Yes.
way, you can take that as a cutoff.
Yes,
If
sir.
this, for example, this individual also have antibody against A0201,
Yes, sir.
which is say 1300.
Yes, sir.
So usually they do not develop antibodies against their own antigen. So you take that as a cutoff and take the antibodies against 0 to 0.5 as a ratio of that and see how high is that,
Yes, sir.
right? So that's how you interpret. Okay. So no antibodies against class 1. Class 2.
Class 2, the Mfi values are given more than 1000.
How much?
And I have directly. So we are looking at DRB1 701, and for 701 I have highlighted in that. Yes, sir. Against that, the MFI is 5575.
So
the green color, Ramya? No, green is all.
Ma'am,
So
green color.
0171.
No,
it's a
ma'am.
DP,
Just pause.
0701 was the mismatched, correct?
Yes, ma'am.
So
Yes, ma'am.
here
Green
it's
I have
on
just
top.
highlighted
It's on
because they are
top.
positive.
DRB1. Yeah,
0701.
Yeah, it's so small, it's not readable here. So the
so
top
0701 is
0701.
this left hand upper corner, yellow.
Yeah,
Yes.
0701. So this is 5500 approx.
Yes, ma'am.
Yeah, there it goes. Here. So this
Okay,
is the
so-
top.
The other DRB1, 4 and 3, 5 are positive, but we don't have that represented in the antigen, in the HLA of the donor.
So they are anti-HLA antibodies, but not donor specific.
Specific. Yes,
Right?
sir.
So this
Correct.
patient
Yes, sir.
has anti-HLA antibodies against different antigens. One
sir.
of them is donor specific.
Yes, sir.
Rest are non-specific.
And in
Right?
DR, they are non-specific, sir. But in DP also, we have high titer, 7000 and
So you
6000.
also get the DP typing and DQ typing.
Sir, we get that done if it is positive, if it is high and significantly positive.
Yeah.
Yes, sir.
So there were antibodies which are high titer in DP.
Yes, sir.
And
So because
DQ
no,
are
sir, we don't have in DQ.
DQ 1800, 1700. So low titer of DQ.
Yes, sir.
So DP 7000. So you got the DP typing. So what was
Yes.
the DP type of a patient?
It was DP-B1 0201 and DP-B1 04 and 01. But here we have DP-A1. The positives are for DP-A1, sir, not B1. For the
DP-B1 0201. So this was 1000.
Yes, sir.
And 0401 900.
Was 900.
So they are less.
Yes, sir. So we had significant antibodies against DRB1 0701, sir.
Yes.
So sorry to interrupt. Now can we try again, because there was some internet problem. Now it's back. So can we try the share screen?
Yeah,
If you
though
need
we
it
are
to be-
almost done.
Almost
Oh, you
done
are,
here.
okay, ma'am. Okay.
I
Sorry.
think Manoj, ask the audience if these things are clear to them. It may not be a bad idea.
So
If
if
they have any problems.
everyone else is clear on this, you can write it in the chat box. So for this, now how will you proceed?
So for
What-
this, we have
Yeah.
calculated the relative intensity score, sir.
What is that?
Relative intensity score is calculated based upon the MFI value against different antigens, HLA antigens of the donor. So we had only one donor specific antibody being produced against DRB1, that is in 5000 titer,
Yeah.
to which a score of 5 is given. It
Okay.
is suggested that if the relative intensity score is more than 17, it is not a good idea to desensitize the patient and go ahead with the transplant. Less than 17 is a safe score, and we had a score of 5 in this patient.
So what does that score mean to me? I don't know of this score. Can you explain?
Sir, it means there are high titer of antibodies against multiple antigens. If the score is high, it means there are high titer against multiple antigens.
Multiple antigens. Okay. So if there is, so you think this 5000 is a high titer or a low titer or an intermediate titer?
Sir, it's an intermediate titer. More than 10,000 is considered a high titer.
Is it an absolute value of 10,000? How do you decide that?
No, sir. There are
How-
no guidelines or absolute value. It is.
Mhm. So how do you decide what is high and what is low and what is not significant? These MFIs are relative intensities. So they vary from lab to lab, right? And from batch to batch. But generally, it's up to the lab person who are doing it. They decide what is the significant value based on their correlation with the cross match.
Yes, sir.
Given that variability, most of the lab would say that less than 2000 titer is
It's not.
usually not very significant and it doesn't give rise to a positive cross match. And the outcome of these patients is generally good. So that's how they said, okay, anything less than 2000 is not very significant. In India, most of the labs which do it, SRL and all, they give you just based on 1000. Okay, less than 1000 is not significant, more than 1000. They give you a titer and it's up to you to decide.
Yes.
So is this titer, does this titer correlate with your clinical, say, CDC or flow cross match results?
No, sir.
No. Why?
Like very strongly, if the titers are really high, that can cause a strongly positive flow cross match or a CDC. Yes, sir. If CDC is, I mean, if the MFI values are really high, yeah, it will be strongly positive CDC and flow.
So does this titer correlate with your
Yes.
clinical?
Yes, sir.
Yes,
It does.
right.
It does.
So generally speaking, more than 8000 will give you positive CDC cross match. Okay. Between 5000 or say 3000 to 8000, it will give a weak positive or only flow cross match positive. And less than 2000, it's usually flow negative. Okay, that's how it correlates. So your flow cross match or CDC cross match coming weak positive correlates with this titer of antibodies. Okay. So this patient has so what do you think is the risk of rejection in this patient?
CDC weekly positive, sir, and
No.
DSS
This patient. So negative CDC, a weak positive flow, and a
And a positive
5500
CDC
titer of
was
1
weak
antigen.
positive.
So now we are specific to this patient.
Yeah.
sir, it is similar to a patient who is having a low immunological risk.
Low.
It is around
No.
70,
You
around
don't say that,
20%.
Ramya.
No,
So
no, no. It's
can you put a
around-
percentage of the possibility of AMR in this patient? Because
I will
we have
around
to give her a
20 to
percentage.
20 to 30% is
That's
the expected, as against 20 to 30%.
okay. So this comes into the intermediate risk, intermediate to high risk. If your CDC cross match is negative, flow cross match, as you said, is weakly positive, and you have one anti-DS, the anti-donor specific antibody or one donor specific antibody, which is 5000 titer. So this will, according to me, will classify into a moderate risk or intermediate risk. Right? So what are the options for this patient? How will you proceed with the transplant?
So she came to us with a donor, live related donor available. So I will proceed with a transplant with the same donor. If at all she doesn't have, I would think probably of a deceased donor or swap transplant in this patient.
So
No. I think what he meant was, how would you proceed with this donor recipient pair? Is that right?
yeah. So will you reject this donor or you will ask the patient to get
Accept
a
with certain
new donor?
limitations.
I will accept this patient, and I will do a desensitization for this patient and take up for a transplant.
Okay. So if I am managing this patient, the first option for this patient is to look for another donor, if
Yes, sir.
possible. Okay. The chances is that she gets another donor. What do you expect?
Sorry,
So
sir.
one, you have to look at the depth of sensitization. For this patient, for example, we have evaluated that this patient has a moderate risk of rejection with this donor. But he has anti-HLA antibodies against different molecules. You have highlighted those green antigens. right? DRB107 was donor specific. There were other antigens where he has similar type of titer, which are not donor specific. For example, this lady get another donor. Chances are very high that she will have antibodies against those donor as well, right?
Yes, sir.
Which we call PRA, panel
Yes,
reactive
sir.
antibody, right?
Yes, sir.
So she will have antibodies against a panel of antigens. So the chances of getting a negative donor is less in this individual because she is widely sensitized,
Sensitized.
right? So you look at the depth of sensitization, how strong is the sensitization, and how broad is the sensitization, how non-specific. So she has a different antibodies to different antigens, but the titer is not very high. So the depth is not high, right? The chances of getting another donor who is negative is less. Whereas to desensitize with this donor is not very difficult. There's
Yes.
just one antibody which you can easily eliminate.
Yes, sir.
Okay? So that's
Yes.
how you have to look at the sensitization.
So,
So you may ask for a new donor, but the chances that she will get a negative donor is still less.
yes, sir.
So other option is, should you desensitize this donor?
Yes,
Okay.
sir.
So how will you desensitize?
Sir, the protocols are either using a high IVIG doses or a low IVIG. In this patient, we have used a low IVIG protocol.
Low IVIG.
Yes, sir.
Okay.
We have given rituximab 2 weeks prior to the date of transplant.
Mm-hmm.
And then we have done sessions of plasma exchange, 1.5 volumes on alternate day.
Mm-hmm.
And post each session of plasma exchange, we have given around 100 milligram per kg of IVIG.
Okay.
She didn't tell this in history, sir, because we have done that, I'm telling
Yeah, no, I understand that.
you.
So what are you chasing? How will you decide now this is the right time to go with the transplant?
Sir, ideally, it is ideal situation is repeat the CDC flow cross match in DSAs, relook at the Mfi values, and if they come down, ideal time is that to go for a transplant.
Okay, so will you do a repeat cross match after doing plasma exchange and see whether the cross match has become negative?
Yes, sir.
But she received rituximab.
Rituximab,
Which
yes,
might
sir.
give you a positive cross match.
Yes, sir.
So how do you handle that?
So that is by pronase digestion.
What is pronase?
It is used to remove the CD20 receptors present on the B cells.
So how
So
good
that
is
removes the
that?
effect of, sorry,
How
sir.
good is that test?
Sir, the problem with that is it can also remove actually the HLA antigens present.
Yeah. So even if it is negative, it may be false negative.
Yeah.
So I don't trust that type of test, for example, right?
Yes, sir.
Okay. Second, you said you will chase the Mfi values.
Yes, sir.
So the Mfi, what determine an Mfi value in addition to the titer of antibodies?
Representation, the amount of antigen representation on the antigen bead.
Yeah, so these are usually standard. Say beads, they are artificially made. So they have a standard amount of antigen on each bead. Cross reactivity of these antibodies, if they are competing antigens, so some of these antibodies will bind with other antigens. So you will have falsely low value. And once you start removing it, it will bind to the most antigen where there is a maximum affinity. So your MFI is not a true indicator of a titer. It gives you some basic idea about the titer, but it will not give you the exact titer of antibodies.
Okay, sir.
So chasing MFI generally doesn't help. And it's an expensive test. You can't do it again and again every alternate day after every plasma exchange.
Yes, sir.
So how did you go?
We didn't repeat the test, sir. It was the
You
same
didn't repeat the
methodology.
test,
No, sir.
right? So
Yes.
based
That's
on the
the reason
titer of
behind it.
antibodies or MFI initial, your moderate risk, you determine, okay, that's what I will do. I'll give rituximab, I'll do plasma exchange. It's just a dream that you had. Okay, I'll give 5 plasma exchange and then do the transplant. In my view,
We
I
had
would say,
actually
okay, I'll
planned
just
for-
give 1 gram of IVIG and do the transplant. Somebody will say, okay, I'll do 2 plasma exchange and do the transplant.
Yes.
Yes, you're saying something.
Oh,
Yeah.
so we had actually planned for lesser number. And I think one day her transplant got cancelled for some reason. So then we gave her, I think, 1 additional. I think we had planned for 3. We ended up giving
5.
It was more for logistic reasons that somehow the transplant got delayed. So we were planning even lesser.
So basically, it's your experience which will determine
just
that.
a guesswork.
Guess and experience, you determine how much do I have to do this transplant. Some people will not just give any desensitization. They will take it with a moderate immunological risk, give ATG and keep the TAC level 2 on the higher side and see what happens. In fact, I have done such transplant where the antibody, let's say MFI was 7,000, just single antigen, single antibody. We did not do any desensitization. We take this patient for transplant with ATG induction and immunosuppression, normal immunosuppression. So that's, you can decide any of these depending on how much risk you want to take. Okay, anything else? Any question?
So Ramya, if you had to ask her for another donor, let's say she said she has more donors,
Yes.
and who would be preferable? She gives you 2-3 choices.
Ma'am, I would ask her siblings to come.
Yeah,
come
that
forward
would
for
be the best.
donation.
Anybody from the husband's family would be a poor match again, because she's
Yes.
sensitized to those. And most like, if you can get a 6x6, let's say a sibling, that would be the best choice.
Yes.
Is there a difference between 6x6 match and 2 haplotype match?
Once I had said that, I knew this was coming. Because
Sir, both are same, sir.
Both are same. No,
Mm,
they're
mm,
not same.
One haplotype
Cannot
is 3 antigens
Look,
similar.
even you and I can match six antigens.
There is chance, 1 in million chance that you two can match 6x6.
But there is anyway.
Okay.
But
So
we
this is
still
a
may not be-
random matching. So you may have incidentally all 6 antigens ABDR matching, but the HLA it goes by Mendelian characters. So all half haplotype goes together. So if both half are same, then you have 2 haplotype match. Then the assumption is in addition to these 6, rest all the antigens are same.
Then you
have
are a 12
inherited
by
all
12
these
match then.
Okay. So what do you expect is the outcome? Say the patient has asked you, okay, what is the risk? You're saying, okay, let's go ahead. There is a moderate risk, but I don't understand what is mild, moderate, severe. You tell me what is the risk in terms of percentage.
Sir, in this patient who has a DSA positive and also a flow cross match positive, the risk that she can have a graft loss is around 30% at the end of 5 years.
5 years.
Yes, sir. This is the OTPN data.
Yeah. And if the CDC cross match is positive?
That is more risk. Around 40% is the chance of graft loss. This is all despite desensitization.
So why do the transplant? She said, okay, I don't want to take that risk. I am happy staying on dialysis.
No, because the risk of mortality is higher when the patient is on dialysis when compared to patient who has received a desensitization and HLA desensitization in the transplant.
If there is no option of transplant, what if you put her on a cadaveric kidney transplant list?
Sir, again, the
She is
waiting
young,
time
she will
is-
get a kidney in next 5 years or 10 years.
So there are also studies which have looked at deceased donor plus dialysis versus HLA desensitized patients. The outcomes are better in HLA desensitized patients. The mortality outcomes are better in them when compared to patients on wait list and dialysis patients.
Yeah. And again, just because she has, as I said, a wide breadth of sensitization, she has high PRA, right? So the chances of getting a match donor even on diseased donor is less.
Yes.
So good. I just have few slides, what we have discussed already. So let me share that as well. So if you look at the Hle sensitization, this is the old data, UNOS data. Almost 36% patients have antibodies. These are the patients who are waiting for kidney transplantation on diseased donor. Okay. So 1 to 10% PRA, 4%, 11 to 50%, 10%, 50 to 80%, 6%, and more than 80% is around 16%. So 1/3 patient would have some PRA, and that determines the outcome, lower graft survival. Okay. So if they have a low PRA, the chances of 5-year graft survival is 70%, whereas if the PRA is more than 80%, the survival is less. How do we detect? As we said, CDC cross-match, this is a flow cross-match. T-cell cross-match, they usually report positive when it is more than 50, and B-cell cross-match when it is more than 150. So negative, how much is the shift from here? It is called channel shift. Same way, MFI is on Luminex single bead assay, and that depend on the titer of these antibodies. So that's how, as I said, classification of antibodies. If it is high, more than 8,500, there is a high risk, and this usually correlates with CDC positive cross-match. From 2,000 to 8,000 is moderate risk, so it will be like flow positive, either weak or more, but CDC negative. Okay. Low risk is when CDC and flow is negative. Okay. Less than 1,000, very weak antibodies, and usually all the tests are negative. So that's how is the correlation between DSAs, flows cross-match, and CDC cross-match. And these are the outcomes. Okay, the top line represents the compatible patient where the flow is negative, CDC is negative. Okay. This line is when the flow is positive, weakly positive, less than 300 channel shift. Okay. Third line is when the flow cross-match is positive, more than 300 channel shift. And the lowest most line is when the CDC cross-match is positive. Okay. So this is 2-year graft survival in days. So approximately 2 years. Most of the graft loss which occur, they occur initially because of antibody-mediated rejection. Right. So if they do not have these antibody-mediated rejection, then both all these grafts go parallel. So the long-term outcome. Same thing is here. This is the graft loss, right? If the CDC cross-match is positive, there is a high chances of graft loss over 5 years, as you very rightly said. The chances of graft loss is around 35 to 40%. If CDC is negative, flow is positive, the chances of graft loss over 5 years is around 30%. If only Luminex is positive, flow and CDC is negative, or if there is all the tests positive, the chances of graft loss is between 15 to 20%. So that is the long-term outcome in these patients based on their risk, immunological risk or sensitization. That's what we talked about. Say, this green line represents the patient who have stayed on dialysis. Orange line is patient who have waited for the cadaveric transplant and subsequently got the kidney transplantation. And this blue line represents the patient who got desensitization and got the transplant. So there is a survival advantage to get the transplant early, even after desensitization. Taking that risk is worth it, right? So the patient who have no other option, they have to wait for the donor kidney. And if they have a donor with moderate risk, you can desensitize these patients and do the transplant. So that will give them an advantage in terms of survival. Any other question or comment you want to answer? There is nothing in the chat box, I guess, which we have not answered.
Yeah, nothing specific.
Any last comment you want to give?
No, I think Ramya, you've done reasonably well.
Yes, I think it was a very well presented case and worked out,
Definitely.
and you have done very well. Okay,
Yeah, it's time.
good night.
Sure. Good.
Bye.
Because with Ramya and me, it was monotony. So I thought there should be somebody from outside. Okay, thank you, Ramya.
Thank you, ma'am. Thank you, sir, for taking.
Thanks,
Thank you,
thanks everyone.
Thank you, sir, ma'am.
Puneet, what's the
Yes.
way to increase this participant participation?
Actually, we are getting around 70-75 from last few weeks, but I think today, because of Onam and all, and
there is
participants from south,
active
down south.
participation from them.
That is a
That's
point,
what
ma'am.
I
I
meant.
think, yeah,
Not
ma'am.
the numbers, but the quality and
But the quality,
some
yes, ma'am.
involvement.
That I think it must be discussed with the students. Maybe offline classes would be of better help that way.
Yeah, that's what I think.
Mm.
Maybe we should start physical classes.
Yes,
Anyway,
ma'am.
Dr. K wrote maybe 2023.
Yeah, ma'am. Yeah, ma'am. Very soon we'll be
That's
starting with
what
that.
we are looking
Yes,
at.
ma'am. Sure, ma'am.
All right.
Thank you. Thank you so much, ma'am. Thank you.
Thank you.
Thank you, sir.
Thanks.